Welcome to episode 47 of the Lebanese Physicians Podcast. And today we will be discussing the politics of healthcare in Lebanon, specifically, and in the region, in the Middle East region. And with us today, we have three guests. And actually, when we look at where each one of us is, we're in four separate time zones right now. We've got Dr. Shireen Bazan, who's in Beirut, Lebanon right now, and Alexandra Chen, who's in London, and Ed.M. Coutts is in Dubai right now. So welcome to all of you to the podcast.
Thank you.
Thank you, Khalil.
And,
Thank you, Khalil.
And before we start, I'm just going to introduce our different guests. So Dr. Shireen Bazan is a family medicine and anti-aging specialist who is currently based in Beirut and works at Clemenceau Medical Center, which is affiliated with Johns Hopkins International. And she has been involved with the care of post-cancer survivors, and she has done her anti-aging studies in Toulouse, France. She also is a lecturer at St. Joseph University. Alexandra Chen is actually a child and mental health specialist who comes from Hong Kong originally. And she has been involved in the Middle East region, including Lebanon, Jordan, and other areas, including also South Africa, and has been involved with the care of refugees and with child mental health. She has 15 years of experience advising the UN, the World Bank, and local governments to design interventions for children and families affected by conflict and adversity. And Ed.M. Coutts is an academic at the University of Cambridge in the UK, has been living, working, and studying in the region since 2008. He's co-investigator on the £6 million Global Challenges Research Fund project, Research for Health and Conflict. This is a multinational project linking the UK with partners in Lebanon, Jordan, Gaza, and Turkey. And Ed.M. is very connected to Lebanon, as his wife is Lebanese too.
Yes, some skin in the game.
Exactly, he's got some skin in the game. So I'm going to ask Ed.M. first. How did the idea for your project or the movie come about, discussing the politics of health in Lebanon? And what's the research for the Health and Conflict project looking at?
Well, yeah, thank you for having us, Khalil. So we've been working, living in the region since 2008, 2009, in Syria, then Lebanon, Jordan. Yeah, it's using things that I'd seen in the UK about how politics and the social economic determinants of health affects people's well-being and health. Does that go on in the Middle East? Yes, it does. These countries are not much different from each other in this sense. So that's sort of the kernel where it's come from. And the project that we've been doing over the last 5 years with colleagues at the American University of Beirut and King's College London, with Professor Richard Sullivan, Professor Priti Patel, and Dr. Fouad and Professor Shadi Saleh, is to look at how the non-health factors affect people's health and how that affects health services. So that, as we've discussed in the report, which is worth reading, not just to watch the film, but health is not just about health services. It's about how where you live, the job you do affects health. But the crux of it all is about how politicians make those decisions as to whether is health prioritized as a public policy issue, or is it not? It's in the pandemic, we saw this thing about lives and livelihoods, health and wealth. So that's really sort of that's the hodgepodge explanation. And of course, yeah, I lived in the region. My parents-in-law lived there. Close friends have been through tragedy and turmoil by living in Lebanon, who were Lebanese, Syrian refugees, Palestinians. So that's the inspiration for all this comes from.
Right, and a lot of times, I mean, we think about the region. People always hear in the news a lot about the conflicts that happen, but we don't hear as much about the social, economic, and health impacts on the population of the region. And this is an interesting study, interesting research and interesting study looking at that. So how did you and Shireen and Alexandra, I guess, meet and get to know each other to collaborate on the project?
So I'd met Alexandra through her work with UNICEF, leading a mental health project in Lebanon and Jordan, I think in 2013. We were all trying to do the same thing. As you know, Lebanon, Beirut is a village, so everybody knows each other. And this is how it spawned that collaboration. With Shireen, I'd met Shireen through my also close friend, Edith Champagne, who's the filmmaker, who'd worked for UNHCR in Geneva and Lebanon over the last 6 years. And my idea, talking to Edith, was to try and get our dry academic subject, because people don't read reports. The guy in the taxi in Beirut does not read a report, or the politicians, either in London or Beirut, unfortunately, tend to not read those reports. So I've worked with Edith before on looking at how Syrian refugee doctors can be integrated into European health systems. And we thought, Edith thought turning our political economy of health report into a documentary film would be a good idea to increase its impact. And Shireen she has a very good way of disseminating information through Instagram, and she sort of knows the scene on the ground.
Right. And it was a good documentary, and it's attention grabbing and also not too long. So for people who have a short attention span, they can still watch it and get all the information they need from it. Of course, we'll have a link for the documentary on the podcast afterwards. And Shireen, I know you met Ed.M, but how did you get involved in the project? How did this come about?
So I know Ms. Edith Champagne since her days here in Lebanon while she was working for UNHCR. And I was approached by her, so I met her. We were in Paris, actually, and she told me about the project. And so we started talking. We did some, brainstorming meetings. We discussed a little bit, and we thought, what is the best way to present this academic paper and to highlight the many challenges Lebanon healthcare system has been facing, and especially the last 2 years that have been very critical for the country. So, and we started thinking, who are the people we should be talking to? Which healthcare facilities should we visit? What are the best locations to shoot, and all of that? And we agreed. And actually, she flew back to Lebanon 2 weeks after the meetings. And we shot the film over a few weeks with the great luck and timing, really, with the shoots. We were, as if, to say the least, divinely guided through the weather, meeting the people. We had great stories. It took some time to put the story together and to review the script, just to have like a coherent feel of the whole thing, because it has to be a short film. And Edith, really, I salute her. She did a wonderful job at pushing everybody to do their best game. And actually, I'm very proud to say that the short film reached around 30,000 views shortly after it was released on Instagram.
Yeah, that's a great number of views shortly after release. And when was the film released?
So we released it after the Cambridge. Actually, it's the first day of the Cambridge conference, which was 21st of March, like on Spring Day. We were in Cambridge, and it premiered during the conference held in Cambridge, and we short released it after that.
Excellent. And hopefully we'll talk about the impact that hopefully the film has had on people in and outside of Lebanon. And so one question I have, now we're talking about the big problems of the healthcare sector in Lebanon, but how was the healthcare sector in Lebanon prior to the crisis? I think we all had dreamt of moving back, and I ended up actually moving back for a couple of years just because I thought it was a good sector at the time. But would you say, that's a question for both Shireen and Adam, I think, would you say, has it been declining over the years, or did it decline suddenly after the economic crisis? And what's the status currently of doctors and nurses before and after the crisis?
So it was before the 2019 economic crisis, it was considered one of the best in the region. We have centers, hospitals, we have cutting edge technology. I mean, medical tourism has always been a part of Lebanon's many services to offer. And actually in January 2019, before the crisis, according to Bloomberg's Healthcare Efficiency Index, Lebanon has reached the top 25 in the world healthcare efficiency. It ranked 23rd, and it proved its ability to accomplish great achievements in the medical field. Now, it's important to highlight here that the healthcare that flourished in Lebanon before 2019 was mainly private, and it was mainly specialized care, but it wasn't the case for primary care. Since the civil war, the private healthcare sector, because of NGO support, both grew noticeably, the private care and the NGOs, and they left the primary care sector very weak and very undermined. And so even healthcare as a tendency, when I started my residency and when I started practicing, it was always a specialist's visit. It was always a curative visit. It was never a preventive visit. The health-seeking behaviors of people were shifted towards private hospitals, which formed around 90% of the hospitals in Lebanon. But if you want to look at it really, if you want to look at the reality of what the healthcare foundation was like, it was a fragmented and complex. Why? Because over 6 ministries govern healthcare coverage in Lebanon. In Lebanon, we say because you have so many cooks, the recipe is going to be, it's not going to be well served. So each ministry had its own limitation and challenge, and so the policies were shaped to affect our decisions. I mean, I as a doctor, and I know many doctors, they ask the people, okay, so what's your coverage, before we actually take a decision about ordering or not diagnostic testing, about prescribing a certain intervention or treatment, about deciding hospital admissions or not. So in the surface, it was a great medical system, but more so for having great doctors, for having great specialized care, but not for having a fundamental strategy to grow universal healthcare coverage for all. And that's my opinion.
Adam, do you agree with Shireen? But what's your assessment of?
Yeah, so I always agree with Shireen. But it's very interesting what she says from on the ground. But if you look at the international stats on Lebanon, it was the best in the region. But that's telling. The best in the region, half the country in Lebanon cannot access basic healthcare services because you have to pay for them. And if that's the best in the region, that's pretty shocking. And that's been going on for 20 years. So if you look at Iraq, Yemen, and those countries, Jordan is a bit of an exception. It's not good. Syria, of course, got a chronic, protracted war going on there. It was, Lebanon, the health system was good for those who could pay. Is the key message.
There were waits for people to go, let's say, to government-based hospitals or to get beds in private hospitals when their insurance is government-based.
Yeah. But if you're talking about providing universal healthcare, which the Lebanese government have been talking about with WHO for years, as it shows in the film and the report that we wrote, that doesn't exist. It's lip service. It's just cosmetic. And I think Alexandra, she's lived in Lebanon. She's married to a Lebanese guy. She sees it every day as well. It's just access and out-of-pocket payments are not manageable for most people.
Exactly, which brings me to a question I was going to ask Alexandra's question, since she's been involved with the mental health care for refugees in Lebanon and the region. Alexandra, what was your assessment of the healthcare sector in Lebanon prior to 2019 in terms of taking care of the vulnerable and the refugees?
Thanks, Khalil. And Adam and Shireen just Always a pleasure to be working with you both. I think it's a funny sort of timeline that we put in terms of prior to the crisis, but I think it's a bit arbitrary in terms of for whom, because if you're thinking about the refugees in particular, the crisis began a very long time ago, and obviously for the Palestinians living in Lebanon as well, it's been going on for even longer. So really, in terms of the vulnerable, a lot of the care that has been afforded to them has been through the nonprofit or the humanitarian efforts, and the care in terms of the psychologists, psychiatrists, and the psychotherapists available have always not been very large in response to the demand, the sheer need for it, from children all the way through the elderly. But even I would say before the economic collapse in Lebanon, there was some provision of it. Mental health is not always prioritized in a humanitarian intervention, but there was greater effort, I would say, definitely before the economic collapse and before also the attention on Syria shifted, of course, with the news. So with that, I think before the collapse then, you had greater service providers. There was an effort, especially when I was in the beginning of my time in Lebanon, when I had just met Ed.M, the effort to officialize, what we called an MHPSS, Mental Health and Psychosocial Support Working Group at the time. And now, there has been great effort to officialize the licensing procedure in Lebanon as well. That having been said, the resources are low. And I think there is also the question of a class division even among the Lebanese who can access mental health services is actually, was quite limited even before.
Yeah, that is correct. Actually, you bring up a good point, because traditionally insurance in Lebanon does not pay adequately for mental health services, whether it's psychologists or psychiatrists. And
correct.
And actually, when I did one podcast, I remember with about the study on the effect of the Beirut blast on children, and I gathered from it that the children who were able to access care were the ones whose parents brought them and were able to pay for their services.
Absolutely.
While some of them were not able to access care after the blast.
For sure. And even then, during the blast, I was in London. I was actually supposed to be in Beirut that week, but something had sort of, I think, perhaps had changed. But even being in London after the blast, I had many requests from parents to support their children. And my youngest patient at the time was actually 2.5 years old in response to it. But the fact that they were reaching out beyond Lebanon also showed that the need was quite high.
Right, exactly. And
I was just, sorry, Khalil, I was just going to add, I mean, I think the key point is that 2019 is not, I mean, that's an event, but the sort of the economic, social, political malaise
precedes that.
Yeah, by years. When I first started living in Beirut, first went to Beirut in 2007, yeah, I mean, you have taxi drivers asking you, can you, instead of paying the fare, can you buy me the medications? And they take you to the pharmacy. So it's not,
right.
It's just a sort of accumulation of trauma that's happened to that country, which started, decades ago, I'm afraid.
Yes. I think perhaps one more point to highlight, Khalil, is that even before 2019, there were lots of pieces of the mental health ecosystem that were unregulated. For example, medication. A lot of psychotropic medication was available over the counter. And when I was living in Lebanon, I would sort of do this monthly round to all the pharmacies and ask, how much had been bought over the counter to get a sense of what people were self-medicating with. And, the numbers were very high, but also, you can imagine creates great concern for how and in what quantities people are using medication without supervision. So that was already happening, before 2019. But now I think there's a new problem of access to even the availability of many medications.
Right. So we were talking about 2019, I know, but it was a progressive decline, I think. So what was the crisis in 2019, and how bad was the economic collapse? Because it was happening slowly, but it seemed like in 2019 there was a quick acceleration of the collapse. And this subsequently led to a huge economic and electricity crisis. Can we just briefly discuss that crisis? And any one of you can take this.
Sure, I could take this. So as you know, everybody knows, after 2019, there has been a devaluation, a progressive devaluation of the Lebanese lira that reached almost around 90% now. And the country throughout this time suffered from a shortage of fuel, of electricity crisis. Even hospitals were struggling to find fuel to keep their generators running and their ventilators running and to keep people alive in ICUs. These are true stories. We lived through these times. We seen, stories on Instagram asking to support fuel for hospitals to keep people alive. But as Alexandra and Ed.M clearly mentioned, these are not why healthcare is in a dangerous position today only. This is not because it is an economic collapse, and this is not only because there is an electricity crisis. The healthcare is suffering today because it's a multifactorial crisis. It's an economic meltdown. It's the massive explosion that nearly wiped out Beirut city in August 2020. And there is a COVID-19 induced public health crisis. And the influx of Syrian refugees from the neighboring war was preceding all of these factors. And so we had a weak healthcare system to start with. We had people coming in, and we needed also to tend and to care for these people. You have an economic crisis. You have a massive explosion destroying most of the stock of medication and quarantina, of chemo medication, of chronic medication. People affected severely, and the COVID-19 made a lot of shortage also in public hospitals. So really, when you look at it, these multifactorial reasons drove healthcare to be at a point where I would say it's an ICU bed right now, if you want to personalize healthcare. And all of that led to a lot of also doctors not believing in this country, and a brain drain. And specialists were leaving, nurses were leaving, healthcare professionals were leaving. So I would say, yes, the 2019 is one of the many, many factors that led to health being suffering and suffocating today.
So I think the way hospitals were affected was basically, I remember when I was there, we used to do the endobronchial ultrasound for lung cancer, and the price of the needle just multiplied by, it was let's say the hundreds of thousands became in the millions suddenly, and people cannot afford that. So you get to the point where you can't perform the things that you want to do, and it gets much harder to practice the good healthcare according to you or according to your values when that happens. But so how would we say the crisis affected hospitals and healthcare facilities in Lebanon? I know there's probably the economic aspect. We can discuss that with the medication availability and then equipment availability, and potentially how bad is the electricity crisis on hospitals?
Yes, so as you clearly stated, it was for an elective procedure, you couldn't do it properly. So the private sector and the specialized care became less important in terms that people couldn't afford this care anymore. It was only restricted for emergencies now, for crucial and life-saving, or to those who can pay. You have the amount and then you can pay the sum, or for people who could not pay, they had to seek help or seek other options. And clearly the balance between the private sector and the primary care sector changed. So what was around, let's say, 20% of people coming to the primary care services when I started practicing is now around 80 to 85%. And when we were shooting the film, it was clear that hospitals, and we met with people who were in management, we met with hospital directors, and it was clear that they were suffering from shortage of fuel. They were struggling to get fuel, and healthcare workers were leaving in great numbers. And people were coming more and more to primary care centers, to mobile clinics, to seek symbolically compensated services, or free services, to say the least. So because people could not afford their medication or their fees, the healthcare fees anymore. So from the problems that the hospitals were facing, one is the lack of funding. They were not paid by the Ministry of Public Health for a long time because of the economic crisis. Even the Social Security Fund was not paying them in a timely fashion. Even private insurances, which is a bit shocking, are not paying because of the devaluation of the lira. There was a lot of difference. So what was around 10% as an out-of-pocket expenditure that the patient used to pay priorly now became maybe 50%. And to cope with this, we saw many hospitals had to close entire wards. They had to reduce their bed capacities by 40-50%. And we know from reports that around 20 hospitals are in danger of closing in 2022. So these were basically the problems that we actually touched, and they're very flagrant right now.
Right, and that brings us, I think, to your interview with Dr. Maawad, I think.
Yeah,
in the documentary, when he was talking about closing entire wards, and also he talked about a bit the electricity issue, like how is that affecting healthcare facilities at this point, and what's the status of electricity in Lebanon?
Yeah, so when you asked Dr. Maawad, this was a few weeks after the short film. So we did the short film, it was bad. But a few weeks after, we called him, we said, we're just making sure, tell us how much is it costing you to run your hospital on fuel per day. He said, every single day I have to secure $1,500 to actually run my hospital safely. So it's not only just how expensive the fuel is, it's about how difficult it is to procure it at certain times. The crisis in Lebanon is not like a stable crisis. It goes really in a high pitched, where suddenly you're out of fuel to benzene to run the cars, you're out of fuel for the generators. I remember the summer of August 2021, myself and my husband, we caught COVID-19, and it was the exact same day that there was a massive shortage in fuel in the entire country. We stayed 1 week sick and at home with 2 to 3 hours of electricity for the entire day. So imagine hospitals having COVID patients who need to be on ventilators, running to secure fuel. This must be very, very, very challenging, to say the least.
Right, because most of the electricity runs on generators, which depend on diesel, which is a very expensive commodity. Yes. And probably one of the good things that might come out of this is I think people are shifting to more renewable
solar power.
Solar power, exactly.
True. Yes.
And what's the status of medication? We talked about electricity. That's a problem that costs a lot of money to maintain, to keep the wards open. What about medications? I've heard from people I worked with or from friends that they have not been able to access chemotherapy, essential chemotherapy medications, at times anesthetics for surgeries. How is that still a big problem?
Yes, it is still a big problem. So people are definitely suffering of lack of medication that is getting worse at times. So it's not only unaffordable, some people can't pay, but it's unavailable. Mostly these are chronic medications that are needed to regulate diabetes. Insulin was missing for months from the market. You could run all the pharmacies in Beirut and not find one single, dose of insulin. I would tell you, it happened with me. We caught the COVID, for example, and my mom also. And so we were searching for steroids for her because, with age, you need steroids at some point, and we couldn't find. And I saw many patients, many people who I interviewed in the short film, and they told me that we cannot afford it, we cannot find it. We are relying on our, our family in the diaspora to send us whatever they can to have our chronic medication. And some people, most of the people that I interviewed told me that their monthly income is actually less than 1 a single chronic medication that they have to pay for. So that's when it comes to chronic pills, when they take the pills. But the worst part is that chemotherapy was missing. Like chemotherapy is the treatment, and not only chemo, immunotherapy as well, that keeps a person who has cancer alive. And even targeted medication. And I'm going to tell you a story that you're going to probably find a bit shocking. I don't know. So this is very recent. This is 2 weeks or 3 weeks ago. You know, as I said, I work closely with oncology patients. So we still have people coming from Syria, from Iraq to get their treatments in Lebanon. We still have that. Medical tourism is still here. It's not tourism, but they trust the Lebanese healthcare system. So we were short on an immunotherapy medication for one of our Lebanese patients. So they searched everywhere, they couldn't find it. And so we kindly asked the Syrian patient to please bring with you another box of that same medication, and we will pay you. You know, the patient is willing to pay in fresh dollars for that. And he agrees, brings the box. Our pharmacist tracks the box. The box came from Lebanon. Subsidized medication are sold and they are trafficked to neighboring countries, and they are sold again here in the black market. This is an issue that is normalized to a point where we can talk about it. It's normal to talk about it. It's not a big issue. Nobody's moving and doing something that is sanctionary about this, while this is taken from other people's lives. This is time taken from people's lives.
Exactly. Basically, essential fresh dollars are being used from the central bank, are being used to subsidize the medication at a cheaper price. But then because it's cheaper, somebody benefits from that and sells it outside the country, and then it comes back on the black market.
Yes.
That's a problem. So basically, the deficiency of medications is multifactorial. I think one is maybe the inability to import as much because of the unavailability, I guess, of as much fresh dollars in the central bank. So you lose some of the subsidies on the medications and you don't import them, or they just become, if you subsidize them, they go elsewhere, or they're just very expensive that people cannot afford them.
Yes, many layers to that.
Exactly. And as we talk about this, we need to, we're talking here about the effect of the, I think, healthcare crisis on people, even people who are middle class or people who are rich and have the means. But Alexandra is involved a lot with refugee care, and I want to ask her, how have these multiple crises affected the Lebanese and refugees, especially the mental health of the Lebanese and the refugees?
Thanks, Khalil. So unfortunately, as you can imagine, this has really impacted negatively the mental health of both Lebanese as well as the refugee population. The first I would say is that the sheer numbers, the overall numbers of those who are experiencing some level of mental suffering has been greater, at the same time that the number of providers in country has been dropping. In addition to that, the intensity of the suffering is also has been quite remarkable. During COVID, we saw a really sharp rise in suicidal rates among refugees as well as poor Lebanese, particularly among parents and fathers who were out of work and just who felt desperate and just unable to feed their children. It was very heartbreaking. During the first year of COVID, I was in lockdown in London, but I was on call for several NGOs at Fajr, basically, between 3 and 5 a.m. most days a week. Because that is often the time when parents will attempt suicide because their children are asleep. So we did have multiple emergency calls during that time, and was very difficult. In addition to that, I do think that it's important to recognize that in addition to the traumatic events that have happened on multiple fronts, both on an individual as well as a community level, like the Beirut blast, we also have what we refer to as toxic stress, this long-term exposure to poverty and this really insane uncertainty that Shireen has made multiple reference to, and that has deeply affected young children. Like I said, my youngest patient was 2.5 years old after the blast, as well as the elderly. Men and women alike have been continually and continue to, I think, be affected. and just an entire community still feels shaken by the incident, in particular in the Beirut blast, but the lack of clarity about what their future looks like in this economic collapse as well is a question for them. I think it's important to also note that for the Lebanese, this impact is not just within Lebanon. Those who have felt forced to be in exile, whether they're in Dubai or in Cyprus or in the UK, for instance, continue to be affected, especially if they've got family back home, like we do in many ways.
Right, exactly, because people forget that even if you're an expat, you still have to, especially with the crisis right now, you still have to make sure your family members are supported and
absolutely
and able to access the necessary medications or healthcare that they need in the country.
Mm-hmm. Just also, lots of survivor's guilt, and then, the continual challenge of getting money out of the banks to be able to support any mental health, challenges in addition to other living expenses.
Right. You've been in the mental health sector in the region and Lebanon for a while.
Mm-hmm.
So what are the challenges that the mental health care sector faces in Lebanon, and what are some of the things that are missing or that could be improved upon, I guess?
Yes. Well, the first, I think, is just, as Ed.M has said, the staffing is a huge issue. Vast immigration of professional healthcare workers, including not just the psychologists and psychiatrists, but also social workers, nurses, doctors, and other specialists who have left the country. Some numbers say 40% of doctors, for instance, and then many still are planning, I know, among my own colleagues, to leave within the year. And with that, there is increasing burnout as well. Those who are on the front lines are affected by the combination of, the social political upheaval, COVID, the continued, economic and also infrastructural collapse. Not having internet also means that you can't even do telehealth, for instance. And that has, these are stresses within their own lives in addition to that of their patients. So that burnout I have continued to hear and grows, unfortunately, amongst colleagues in the region, just completely unable to take on anyone else onto the patient load as well. And just the exhaustion we hear in sort of private conversation is very real. The third, I would say, is that, we have, as we've mentioned, the availability of medication, as well as the sustainability and I think the suitability of many of the interventions that we've traditionally used. Many of the psychotherapeutic interventions are borrowed from the West and were designed in many ways to help those who are struggling through a difficult period of time, but in relatively stable settings. But nothing is stable in Lebanon. Absolutely nothing is stable. And so how do you work in a model where you don't know when, you'll get to speak to your patient next, for instance? And often in my work, sadly, I have a quite long waiting list. I'm perhaps one of the few Arabic-speaking psychologists who works pro bono for the refugee community. And so often I will say to them, in order for us, to new patients, for us to work together, we're going to focus on the most pressing needs that you have. But then we may have to take a bit of a break to make room for someone else who's in a very emergency situation before we then go back to addressing long-term therapeutic goals such as developmental trauma, which are very important. But in this really what feels like a continually emergency situation, we have to be pragmatic.
Exactly. Yeah, I think what's hard is just that there's no end in sight at this point. And
exactly.
And one of the things I've heard too about the blast is also there's been no closure. Like you don't know
100%
who did it. Nobody paid the price for this. So that's a big thing too.
Yes, the lack of feeling of justice, I think, also is just an undercurrent of anger and just shakenness in the community.
Right. So I'm going to ask Ed.M to start now, I think. And I mean, we've discussed the problems in both oncologic or cancer care and in the care of regular ailments in Lebanon right now. And we've talked about the mental health challenges of care in Lebanon too. So Ed.M, what do you think based on your experience and based on the reception, I guess, of the documentary in Cambridge, what do you think, what's next for the healthcare sector in Lebanon? What's going to happen next?
Would you like the diplomatic answer or the answer from the street.
I guess both.
I'll give you both. Diplomatically, I mean, for the donors, they see how it works out, as we've discussed, like with the report, and as you know, World Bank, IMF, we'll just see how it plays out. Inevitably, the government defaults. In the meantime, what people need support and help. How is that given? As we saw in the film, NGOs fill that space. So clearly, donors need to keep supporting. A lot of the aid has now gone to the Ukraine, which is needed, but there are multiple crises now in the Middle East, Europe, that I don't think the donors, particularly the UN, are capable of dealing with. It was interesting that a colleague had described Lebanon as the hospice patient waiting to die, except there's no palliative care, which is a shocking statement. And that comes from somebody who's on the ground. So it is grim. And our film reports add a bit to highlight what's going on, but there needs to be serious political will and intervention in Lebanon, the region, and within the UN to do something, because it will. I mean, this situation will eventually end, and you have a war. I think is the ultimate end of that.
No, hopefully not, but that's a possibility. That's correct. So Shireen, you're on the ground too. How do you see things moving forward?
Well, and I'd like to be more optimistic than Adam and the grim description of the hospice and no palliative care. But I mean, it needs to have a conscious political dialogue where the healthcare is at the center point of interest and not private agendas of each ministry or each party or each political party that go, before the well-being, the sanity of the people. I mean, I lost my best friend because she traveled, she immigrated. Many of my colleagues left a country whose doctors are leaving, whose great doctors are leaving because they have opportunity outside. These people are leaving because they can. So the people who are staying here, they are staying by choice, but as Alexandra clearly mentioned, they are suffering from burnout. And they are, desperate at certain times, maybe feel helpless. These are people who studied years to be able to serve people. They went through med school. And the least is to give them a decent country first to be able to keep the people sane and alive. So what's next? I'd like to think that the elections that are coming, soon will change a certain profile, a certain way of doing things. We will have a long-term strategy and a very, very quick, dramatic short-term solution. But these are all, hopes and speculations.
So Shireen, how do you feel? You're practicing in private clinics and also practicing with NGOs on the ground there. Do you feel burned out yourself, or how do you feel? What's your feeling about the situation?
I mean, currently, right now, I am not directly practicing with NGOs. I used to do that when I was just finishing my residency, and then when I started the primary care. I mean, the primary care, healthcare in Lebanon didn't encourage me to stay in primary care, and that's one of the problems. I too shifted to more specialized care, in the sense where I was driven to work with cancer patients, which is a bit more specialized than just a GP. I take care of a specific population, and now I broadened my practice into anti-aging, which is a more to honestly say is a luxurious medicine. It's not something, it's, when you have problems, okay, you can treat it, but preventive medicine, it's only for the people who really are well, and working with this keeps me sane, and keeps me in the country, and I really take care of myself. And I travel a lot just to keep that balance between, giving a good energy inside the country, helping the people inside the country, but also, I'd say, releasing the cumulative stressors that we face here. That's a bit my personal experience about the thing.
Okay. And Alexandra, do you share the same grim outlook too, or do you have a different outlook of the situation?
Again, I would love very much to have a different, an alternative reality. But I do think the way that things are going I hate to say this, but in large part, the ripping off of the Band-Aid has been extended because the Lebanese are so resourceful. And so, they have really, I think, tried in every possible way to fill the gaps and make it work. But in doing so, then the weight has been on them, just like it has been on civil society for so very long. And unfortunately, moving forward with knowing, those who I know who are planning to continue to leave, I do very, very much worry about the region, particularly as so much of the attention is now obviously on other crises in the world, and funding for the region decreases as well. So, like Ed.M said, there is an enormous need for actual political will if this is to turn around.
Right. And I will get from all of you after offline, we'll get some specifics on some of the NGOs that are working on the ground, and maybe suggestions for donations to these NGOs. And hopefully we'll get follow-up. I think we saw a lot of people being interviewed in the documentary, such as Dr. Mawad and his hospital, and others, and certainly, hopefully, with time, we'll get some follow-up on the situation of these individuals who were interviewed in the documentary.
Yeah, sorry, Hillel, just to add, not to add to the pile of misery, but a lot of these things can be fixed by political will.
Right.
But it is clear in the region, Syria, Lebanon, that health, the well-being of populations is a low priority. This is what we found in our report. This is from 10 years of research. People prefer to play sectarian politics instead of taking care of dialysis patients or the elderly. That's. Yeah.
And that's why I think it's going to be important. I mean, the elections in Lebanon are coming up, and on May 15th, and in the diaspora, the elections will be May 6th and May 8th. And I think that's why it's important for everybody to get out the vote, and maybe things will change. I don't know, hopefully.
I don't think so. It's entirely predictable, I think.
I agree, but I think...
This is cut from the podcast, but...
So hopefully, finally, the last question is where is your research taking you from here, Ed.M?
To support people on the ground, civil servants in Lebanon, the region. Our universities in the UK, US, Europe are ready, waiting to help. As Shireen and Alexandra, but it can't. These things can't be done on a shoestring by academics. It needs serious UN political will.
Right.
Can't emphasize that enough.
And any final words, Shireen and Alexandra?
I think we covered really most of the very important points about this, and thank you. I would like to thank everybody for participating today. Thank you, Khalil, for hosting us. It's been such a pleasure to share these findings and information, and to speak these out loud, and hopefully we can reach many and raise more awareness about this issue.
Absolutely. And again, thank you, Khalil, for even elevating this on your platform. I think perhaps my last thought is that the diaspora has a role. The diaspora absolutely has a role, even on the day-to-day, being able to support the morale of your everyday person, but as well as the healthcare staff in Lebanon. And I think that not to belittle that, because at this point, really everything counts. So that sort of support helps people feel that they're not forgotten and really taken for granted in a system that they're really trying to still uphold.
All right. Thank you. Thanks to all of you for being on the podcast. And hopefully we'll see you all sometime in Lebanon, I guess, when I visit this summer. Maybe we'll contact you and we'll see you all there. Thank you.
Yes,
Great
please
pleasure.
do. Inshallah.
Bye.
Cheers.
Bye.